I'd like to welcome Rene back to the podium. Rene will be talking about something very interesting that's we've been doing at Next Step in the last 18 months or so with regard to a new approach to opioid rotation. So thank you, Rene.
Thank you, Richard. Hello again, everyone. So this presentation probably follows on very nicely from Mike's presentation in the sense that it is about buprenorphine and substitution treatment. And thankfully to Mike, I don't have to go through a few slides because he's already done them. So look, we know you know all about buprenorphine now. And I guess the thing to start off with is that it is used for pain management as well. We know that the formulations of Temgesic, sublingual small doses of buprenorphine used in hospital quite commonly, and the transdermal patch, Norspan, often used for chronic pain. Now, when it's used for the treatment of opioid dependence, we're talking about using doses that are considerably higher, as you would have got from Mike's presentation. And as a result, the induction process, so we're sort of going one step before talking about Buvidal and everything else, the induction process from full agonist opioids can be a little bit complicated. So that's sort of the crux of this presentation, and basically this talk is about a novel method or a relatively new method of rotating people from full agonist opioids, whether it's prescribed, illicit, onto buprenorphine that potentially gets around some of the problems that we'll talk about. So I'm going to skip this and this one. As you can see, we use the same slide, so we don't really bother about plagiarism. And I'm going to skip this one. Oh, this one. Okay, so I'll start here. So we need to think about the issue or the concept of precipitated withdrawal. And many of you, if not all, will be familiar with this because this is what happens when you give someone who's opioid tolerant naloxone. But a similar thing happens with buprenorphine. But for the sake of people who are not as familiar, I'm just going to go through this in a little bit of detail because it has a lot of relevance to microdosing. So essentially, precipitated withdrawal happens because because of buprenorphine's effects as a partial agonist, and also because of its so it's got lower intrinsic activity than full agonist opioids, but also the other really important thing is it's got very high receptor affinity, as you would have gathered by now. So the phenomenon of precipitated withdrawal is basically a very rapid and intense onset of withdrawal symptoms. So all this kind of symptoms that goes with withdrawal, the cravings, anxiety, restlessness, diarrhea, tummy cramps, sweating, tachycardia. And the reason for that is at the molecular level, and hence at the symptom level as well, patients will go from, it's really a sudden drop in activation of the opioid receptors. And you go from full agonist activation to partial agonist activation, and this happens within a span of minutes. So when that happens, you basically get a sort of milder form of what you would get by giving someone naloxone. All right? So just keep in mind this diagram here, which came from a paper from Canada. So if you look at the orange shape, so that's potentially methadone or heroin or whatever other opiate the person is tolerant to. And the blue sort of shapes that partially fill the receptors of buprenorphine. So what happens with precipitated withdrawal is when you give someone a reasonable dose of buprenorphine, you give it a little bit too early, you get that rapid change, and people don't really like that. So they experience that precipitated withdrawal. So this actually relates to some of the challenges that we face when people are being started on buprenorphine. And remember that we're talking about higher doses. We're not talking about 0.4 milligrams like Temgesic or the lower strength in the patches. So general approach is that we need to wait until a patient is in withdrawal before we commence buprenorphine. So whether it be Subutex or Suboxone, or indeed we don't generally start the injections directly. So the current induction guidelines actually require the presence of moderate withdrawal before the first dose of sublingual buprenorphine. And this can be 12 to 24 hours for short-acting opioids, but it might be as long as up to 72 hours if you're talking about an opioid like methadone. Fentanyl is very complicated because that can last quite long as well, even though it's a short, it's a rapid-acting opioid. So the problems there that come about is that it may be a barrier to starting treatment for a lot of patients, particularly the ones at most risk that we want to try and put on buprenorphine rather than methadone sometimes. It's an increase in risk in terms of relapsing into treatment relapsing into use when they are on treatment. So people tend to drop out of treatment if they feel that they have any of these adverse effects. And indeed, some patients may actually avoid treatment altogether. It's not very uncommon for us to get patients who receive for the first time, and they will not, no matter what you do, you say to try and convince them, consider buprenorphine as the treatment option, because either they've experienced precipitated withdrawal before, or they know someone who has. So there's a lot of demystifying that goes into providing treatment as well. It takes a lot of time. In the area of chronic pain, patients are potentially even more vulnerable. So opioid abstinence may cause an increase in pain for opioid-tolerant patients. As remember, I mentioned before in the previous presentation that withdrawal can be a strong precipitant for pain, and indeed is part of pain as well. That results in a lot of potentially treatment dropout or non-commencement. So patients on methadone and fentanyl, research has found are particularly vulnerable to these adverse effects. Now, one of the more complex tasks in OST is trying to transfer patients from methadone to buprenorphine. And there are a number of reasons why patients might want to transfer from methadone to buprenorphine. They may prefer the convenience of not having to dose every day. They may be thinking about going on to the injectable formulations. It may be that the methadone potentially has adverse effects, or potentially people go on to buprenorphine to try and come off methadone as well. So a number of reasons. Current Australian, American, Canadian guidelines are all quite similar in the sense that they recommend gradual reduction of methadone, tapering to a dose of about 30 milligrams or less, and then transferring to buprenorphine, stopping methadone, waiting for evidence of withdrawal, and then initiating buprenorphine. So pretty much what I said in the previous slide, waiting for evidence of withdrawal, and sometimes waiting for longer than a day. The problem with this is some patients may be at increased risk of destabilization during the prolonged tapering of methadone. It's not uncommon for patients to take months, if not years, to come down from a dose of 80 milligrams or so to get down to around 30. And if it's a situation where that needs to happen quicker because of health issues or because patients want it to happen quicker, then that can be a problem. There have been factors that have been identified that potentially increase the risk of unsuccessful transfer from methadone to buprenorphine, and they are as listed there. So patients who are already experiencing withdrawal on the methadone dose of 60 or less, so they tend to do not as well. Patients who are actually still using unsanctioned opioid use and unstable use of other drugs while they are trying to reduce, that's pretty understandable. If there are severe medical or psychiatric complications, unstable social conditions, if they have had a previous negative experience or complications associated with trying to transfer, then often these patients don't attempt again, or they may not do very well. And also, obviously, it's really important for patients to understand what's happening. And I can't emphasize this enough, so that it's really important to prepare patients for this change of treatment, noting that there is quite a significant difference between how methadone and buprenorphine is perceived by patients. So we come down to the concept of bridging. So this is the concept that underlies microdosing. So I finally got to the topic of the presentation. So what the concept of bridging means, remember that diagram that a few slides ago? So bridging actually involves very, very gradual introduction of buprenorphine, which has higher affinity, onto the opioid receptors without significant displacement of the full agonist opioid, whether it be heroin or morphine or oxycodone or methadone. So by doing this, it minimizes withdrawal symptoms. So this is the concept behind microdosing, and I'll get into more detail with that in the next slide. So what it looks like in a diagrammatic fashion is, instead of 20 minutes, you're looking at a period of several days where slow introduction of buprenorphine onto the receptors gradually takes over the receptors while methadone is gradually excluded. And because buprenorphine has a longer half-life, what happens is there's a progressive build-up of buprenorphine on the receptors. Methadone, in fact, at a molecular level, is probably still just hanging around with no place to attach, or not attaching as much anymore. And this is one of the things that makes it easier to stop methadone at the end of the process. So coming on to what microdosing, where it actually started. So it is also called the Bernese method. And the reason for this is the initial study was out of Bern in Switzerland by a researcher and doctor by the name of Robert Hemmick. So his initial case that they did was in 2010, but he wrote up the case in 2016. And essentially the three hypotheses that he came up with were, as I mentioned, repetitive administration of very small buprenorphine doses with sufficient dosing intervals, such as 12 hours or so, should not precipitate opiate withdrawal. And because of the long receptor binding time, it accumulates on receptors. And also over time, the full agonist opioids will be replaced. So it pretty much summarizes the slide before. Now, how does it work in practice? So one of the benefits of this approach is that the patient can continue on their opioid regimen for a few days. So they continue on whether it's illicit, prescription, methadone. Buprenorphine is then introduced very slowly, as I mentioned, and then it's up titrated. So we build up the dose over a few days while the patient is still on methadone or still on potentially using illicit opiates. For illicit users, what happens then is basically once you get buprenorphine to a therapeutic range, you can very quickly reduce the dose of the other opioid or essentially just stop it altogether. If it's an illicit opiate, patients will expectedly tend to reduce it themselves, or if it's methadone, then it's a prescribed reduction. And once the therapeutic dose of buprenorphine is achieved, basically you can just stop the other opioid. Now the duration varies. In the studies, I must say that the studies so far have been primarily case reports. They've varied between 3 days to about a month, and a month obviously being in an outpatient. What I'm going to just quickly show you here is a few of the case reports in the literature before I talk about our experience at Next Step. And there's quite a lot now of case reports. I remember looking back a year ago, and that's probably half of what they are when I checked a month ago. But there's still generally case reports with some progress to controlled trials. So I've chosen 3 different examples because it gives you an idea of what the applications are. So this is the original Bernese method. And what he did was he looked at 2 cases of patients who were heroin dependent. One of them was being transferred from street heroin. And as you can see there, that gives you a bit of an example of what the induction increase in regimen looks like. So over a period of 8 to 9 days, you've gone from 0.2 milligrams to essentially 12 milligrams. And 12 milligrams is essentially potentially a therapeutic dose of buprenorphine. Obviously, higher doses may have better effects. And the second case was a longer one, and this was a patient who was who was on methadone and was also on diacetylmorphine or prescribed heroin. And this, as you can see, was a longer course over a period of almost a month. But I think this patient actually dropped out of treatment for a little bit in between, where you can see those three missing doses. Well, what they found, if you look at the SALS score, so SALS basically means symptomatic opioid withdrawal scale. If you look at those scores, those are minimal scores. A SALS score can go all the way up to 64. So basically, clearly in his 2 cases at least, they were quite well tolerated. The second case report is about 3 hospitalized patients. So we look at using it in a hospital setting. And again, obviously, the use is dependent on resources and regulatory issues as well. So 3 hospitalized patients with opioid use disorder who were prescribed methadone. This was the dosage regimen that they use, and this has become more or less the standard microdosing regimen across the board. So most case reports that you will see will have a very similar dosing regimen. So that was a dosing regimen they used, and I've just taken one example in patient 2 where the patient was on 100 milligrams of methadone, and that reduced over 7 days, and basically with the buprenorphine increasing gradually up to 16 and then 24 milligrams. So once again, well tolerated. The third case report was using it in the community, and they had the benefit of being able to do outreach where they were able to take the Suboxone to the patient's home, which was very beneficial for that patient. And this was a patient that was very, very difficult to engage, had multiple attempts at being inducted on treatment, but did not manage as a result of poor compliance. And the patient's report was that it was precipitated withdrawal, or just the fear of withdrawal that prevented him from sticking onto treatment. So they looked at a 7-day sort of process of using the microdosing. So while he was still using heroin, they used lower doses of buprenorphine, and he managed that quite well and actually was successful in adhering to treatment. I think that the big difference here when you're talking about illicit opiates is what the message that you're giving clients. We're used to telling clients you need to stop using heroin, you need to wait until you're in withdrawal, and then have 2 milligrams, 4 milligrams, 6 milligrams, whatever dose of Suboxone. But here the message we're giving is that, look, if you end up using heroin, just use it. You don't need to worry about precipitated withdrawal for the first few days. When you feel you're ready to stop using heroin, just stop. There are some disadvantages which I'll talk to you about before. I'm going to move on now to our experience in the inpatient withdrawal unit. And we've used it there. I think our first patient was in April of 2019. So we've used it over the last 2 years. We've now had probably about 8 or 9 patients in total that we've transferred, with potentially quite a few more to come, primarily because they are patients who want to go from methadone onto the injection of Depo. So this first patient we had was by far the most complicated one we've had. So I guess it was good that nothing actually went wrong, because otherwise we wouldn't have continued. So this patient transitioned from a very high dose of morphine to buprenorphine to Suboxone. 59 years old, long history of chronic back pain, lower limb pain, multiple injuries from a serious motor vehicle accident when he was 32. So he was in ICU for a month, ended up being in hospital for 2 months after that. So he was significant injuries, and he was prescribed morphine in the hospital. And back then, it was decided that prescribing him intramuscular morphine on discharge was potentially a good idea. So he went home on intramuscular morphine, which initially was administered by a nurse, but very quickly self-administered. For many years, this was his regimen. He was on prescribed oral morphine and intramuscular injections. And thankfully, no history of illicit or non-prescribed opioid use, and no history of intravenous drug use. Substance use only consisted of cannabis. Past medical history: type 2 diabetes, testosterone deficiency, sleep apnea, hypertension, hypercholesterolemia. Whether it was, which started first, probably a little bit debatable. No doubt his testosterone deficiency and would have been, contributed to by his long-term opioid use. What happened with this patient? For a long period of time, we worked with him. He had a lot of engagement from the pain services in Robert Hospital, as well as Next Step and his GP, to try and encourage him to gradually reduce the intramuscular injections first. There was no way we were going to be able to touch the oral morphine, but he really didn't tolerate this reduction, and it wasn't agreeable with it, so it was really unsuccessful. Finally, the health department authorization was cancelled because the health department, as well as the clinicians, had significant concerns about risk and adverse effects. So he decided that basically he agreed to transfer to buprenorphine. We decided we needed to get him under the dependence pathway. You might ask, why didn't we just put him on Northspan or sublingual buprenorphine instead of something else? Because we felt he needed the higher doses that would not be possible through any other pathway. So he wasn't probably the most ideal candidate from an illicit use point of view for substance dependence, but he indeed certainly was opioid dependent. There were obviously significant concerns about precipitated withdrawal, so we arranged a 2-week admission in the inpatient withdrawal unit. Now, at the time of admission, he was on 600 milligrams of oral IM morphine a day and 700 milligrams of oral morphine. And this was actually lower than what he was on for years. The highest dose I think he was on was about 2,700 oral morphine equivalent dose per day. This was a person that was doing that for years and years and years. So we stopped the morphine injections, obviously, when he came in, but we continued on the oral morphine. So this is a bit of a busy table, but hopefully you can see there what the regimen was like. So if you look at the sort of columns on the left, that was what we had our buprenorphine regimen as. So you can see a very slow starting of buprenorphine. You can see that we continued on the oral morphine for quite a while. So he was on 700 milligrams for about 5-6 days, and then we reduced it over 4 days. We had to keep him for 2 weeks because of the complexity of his pain. We decided to use, in consultation with pain specialists, to use some tapentadol, PRN, to just sort of, in a way, psychologically replicate what he was getting from his intramuscular morphine. Didn't really do much for him, not surprisingly. And we also used pregabalin, or started him on pregabalin, to try and manage some of his neuropathic pain. But interestingly and surprisingly, he actually managed the transfer without any problems at all. The scores do show mild opiate withdrawal. I remember on consultation with him, he would never say that he was in opiate withdrawal. It was always the pain that was concerning. So it was reassuring that he did not actually suffer any adverse events. And what happened to him after that? So obviously there were no symptoms of precipitated withdrawal. He did complain of increasing pain. He struggled with the loss of being able to control the injections. I mentioned we started pregabalin. We did use a little bit of clonidine and diazepam, but he really didn't find any benefit from that. He used it very sparingly. Discharged successfully, followed up with his GP, pain services. Next step, we continued to see him. And he did adhere to the Suboxone treatment, 24 milligrams, undoubtedly as the highest dose, and did not return and still hasn't returned to any morphine use. But obviously still has problems with his pain, which we know we're not going to fix. Second patient, a little bit more straightforward. This patient transitioned from methadone, 75 milligrams, so sort of almost our stock standard patient on methadone who may want to transfer to buprenorphine for various reasons. Now this patient I knew for quite a period of time as well, at 39, long history of heroin use from his teens, basically had never stopped using heroin for any length of time despite long periods of being on substitution treatment, and not surprisingly didn't really like Suboxone in the past because he needed to continue using heroin. He would still use 1 to 2 points a day despite being on 100 milligrams of methadone for some of that period, but his methadone dosing was clockwork, would never miss a dose of methadone, so it wasn't that he was not dosing. He elected to transfer finally. I mean, we sort of worked on his motivation. His kids were growing up. He was looking after the kids. My wife was working, so he sort of said, look, I've had enough. I need to do something about it. So we spoke about the Buvidal because that was newly available at the time. Spoke to him about this method. He was very concerned about being able to come down on his methadone dose and transfer over. So we decided to admit him into the inpatient unit to do that. Obviously, we went through different options with him as well. He did try and reduce his methadone by a little bit, so he went down from 100 to 75 before he came in, and this is what his regimen looked like. So his was a little bit less complicated. We managed to do it over 7 days, which is generally our standard at the moment, and basically got him up to 16 milligrams once a day. He only had methadone for 5 days, 6 days, and as you can see, we went from 75 milligrams of methadone to nothing. We did not even reduce it. And he was, among the 3 patients I present here, he was the one that really had no problems whatsoever. He did describe having some mild withdrawal that would last about 15 minutes, about half an hour after a few of the initial doses. What we found is it's probably day 2, 3, 4 that people notice some difference, and I think that's when you're getting more displacement of the receptors. And interestingly, once people get to around 4 milligrams, it doesn't really matter. The withdrawal symptoms really tail off and they are really completely comfortable. So it's almost a set and leave kind of regimen for us in the inpatient unit with daily review, obviously. You see that the last 2 days we managed to do it in an outpatient setting because he left early in the pharmacy that he was dosing at supported that. So he did well, didn't use much clonidine or diazepam, and basically continued on 16 of Suboxone and is currently on Buvidal and doing quite well. Third patient was a patient that was referred to us by North Metro, or the next step at Joondalup. And this was a community client who was in one of the regional centers who was on methadone for a long period of time, had chronic pain issues as well, and really wanted, upon discussion with the addiction consultant that was helping her, really thought that going on to the injection would be a lot more beneficial for her. She had a history of illicit and pharmaceutical opioid dependence from her early 30s, and her main issue was that she'd been stable on 50 milligrams for a long time. She wasn't really using any opiates, but she was having trouble going to the pharmacy every day, and she just felt that she had other physical health issues, mental health issues. She just didn't want to go to the pharmacy every day. It was costing her a lot, basically had enough. And we got her into the inpatient withdrawal unit as well, once again, almost identical to the previous case, where she was on 50, and she was a lady that was quite anxious, very significant anxiety. So I think, credit to her, she actually did quite well. Her main symptoms revolved around anxiety, which may have been related to mild withdrawal, or may have been just the dynamics of being in a social environment in an inpatient unit. She was very isolated in her home normally. So she progressed well. She, as I mentioned, reported minimal symptoms, if any, and is currently on depot buprenorphine as well. And so one of our consultants here in the audience is kindly looking after her. So what are some of the, just from the cases that we found and looking at the literature, what are some of the advantages from microdosing? I have to say, first up, that it is still an off-label use of the medication, so it's not endorsed in any guideline as far as I'm aware, anywhere across the world. But there are, steps afoot to try and look at, doing a bit more research to try and look at suitable dosing regimens and things like that. So I guess one of the benefits is associated with fewer and less withdrawal symptoms. Some patients don't even describe any withdrawal in the case reports, and similar experience with our patients. It reduces the barrier to starting treatment and potentially improves treatment retention. The research tells us that the attrition rate or discontinuation rate for buprenorphine is somewhere in the region of 10 to 24% at 1 week. So this hopefully may contribute to better treatment retention. It may be helpful for patients fearing withdrawal and experiencing severe symptoms with the conventional method of transfer. And I mentioned before that it's often the most high-risk patients that exclude themselves because of concerns about withdrawal. So basically, this may be a way of helping patients that need help the most without, initiating withdrawal or addressing their fear of withdrawal. It may increase prescriber confidence with buprenorphine and naloxone. So we know that Suboxone is safe. We know that we've got very safe guidelines in terms of in starting treatment, but the issue is between the clinician or the doctor and the patient. So in a GP setting where there's limitations in terms of not having a case manager, there's less time, it can be quite a task to try and convince patients to go into treatment. So sometimes it becomes too hard. It becomes too hard on the prescriber to try and initiate buprenorphine, even though they feel that might be the best option. Switching for methadone, as you saw, that was 2 of our cases involved there. So particularly patients with higher doses, it means that reduction or significant reduction prior to transfer is no longer necessary, and all the benefits that go along with that. Obviously, there are limitations to this method. One is, as I mentioned, there's very limited data and experience, or still limited data, but increasing. It is used quite a lot in Canada, so although the initial study was in Switzerland, I don't think they use it there very much, because Switzerland tends to use a lot more methadone and sometimes more prescribed heroin. So Canada seems to be leading the fall in terms of this method, the States as well. As far as I know, there's no randomized control trial at present to determine methodology, whether it's better than standard practice. Patients should expect to have some elements of withdrawal during the transition. Generally, it's very mild, but they need to expect that it's possible. The duration until stable buprenorphine dosing may take longer. So remember I mentioned 7 days, sometimes in some case reports up to 14. Generally, with the conventional method, you could potentially get patients up to therapeutic doses within 3 days. So this could take a little bit longer. And we have to recognize that there are potential difficulties in replicating it in the outpatient setting as well. The frequency of dosing, generally you need to dose twice a day, and how is that going to work with attending a pharmacy twice a day, although not impossible. The small initial doses of buprenorphine require Subutex rather than Suboxone, and there were, until recently, regulatory restrictions regarding using Subutex for this purpose, but good news is that there is now the potential to use low-dose buprenorphine for a very short period of time, up to 14 days, so using Subutex for difficult inductions from illicit opiates. Yet the splitting of tablets, that's what we were doing earlier on, and now we've just modified our regimen to just use 0.4 milligrams rather than 0.5. And obviously there's the concern about continued illicit use. If the induction is going to take longer, or you're not telling people to stop using opiates immediately, then they're going to be using for a bit longer. But it's all about harm reduction. We know patients are likely to do that anyway, so we need to just address that in terms of harm reduction advice. The cases I described, at least from our perspective, happen in an inpatient withdrawal unit. So trying to replicate it in an outpatient setting or in a hospital where discharge dates might be more unpredictable may be a little bit more difficult. I'm going to skip this because generally this has been covered in the 2 slides before. I just want to highlight that maybe there is a role in hospitalized patients with acute pain who there is a need to transfer from high doses of other opioids if they're opioid tolerant onto buprenorphine. Look, in hospital you're doing this anyway. When you use Temgesic to manage patients on methadone, in essence, you don't, my understanding is you don't really notice much in terms of precipitated withdrawal. And essentially, that's basically what you're doing. The difference is you're not ramping it up to the levels that we are. And in terms of chronic pain, we know that buprenorphine is a safe analgesic. We know that there are limitations in terms of using opioids for chronic pain, but buprenorphine has its advantages over other opioids. So it might be a way of changing people over from other opioids through a microdosing method to buprenorphine, if that's been considered. And I mentioned that already. So what's in the future? There is further research is needed, obviously, but there is a trial in progress at the moment. I don't know what the results are, where they are at this point, which is comparing micro-induction to standard induction. The plan is for 50 participants, which are going to randomize to a conventional induction method and a 3-day microdosing or rapid microdosing method to try and gauge what outcomes they are, in terms of tolerance and treatment outcomes. Thank you for listening. Does anyone have any questions? Yes, Peter.
What would be a recommended management of precipitated withdrawal?
Sorry, Peter, just hold it.
I'm just going to take this over to
Peter.
Just thinking about what options for managing a case of precipitated withdrawal, which we see a lot as an outpatient, inducting people onto Suboxone, particularly or methadone, or in this case, clonidine and Valium. Would it conceivably be an option, even theoretically, to just increase the dose of Suboxone more quickly, just pile on if you go to 24?
I won't. In terms of there's no issues because what we do is we just sort of push on and treat the withdrawal with other symptomatic medications. But we're talking about low doses there. What you're asking about in terms of normal inductions. Generally, as you say, one option is it depends on how much the patient is going to tolerate and how you can monitor them and whether they've got any other contraindications. But one option is to potentially power on. And the research, case reports in the literature do describe just using more Suboxone, because then it gets over, we know that the Suboxone does an opioid effect, so it's not like you're giving that person naloxone. So basically, if the person can tolerate it, if it's not severe, using Suboxone or using a smaller dose a little while after may help. Alternatively, if that's not possible, then it may be that you wait a little bit longer, use symptomatic management, and then try again. So it depends on the situation, I think.
I suppose I think I know the answer to this question, but I'm going to ask it anyway. Does this mean you're going to be taking referrals for this process?
Yeah, we are already, yes. So we do.
High doses of methadone?
Yeah. We are already taking referrals. It can come from Cambridge, it can come from GPs. Most of our referrals so far have come from the CADs or Next Step. And there's always one or two in the pipeline, and I think it's primarily been driven by the fact that patients now know they can transfer over. And I think the limitation is that most patients think I have to come down to 30 milligrams and transfer over, so they don't even think about that option. So I think it's discussing it with them. Obviously, we're not saying this is going to work for everyone. Again, it's off-label. But what tends to happen is if we get a referral, I personally myself or one of the other senior doctors will give the patient a ring and talk to them about the different options. We're not going to say, look, you have to do this. We need them to decide what they think is best for them.
Thank you, Rene.
Thanks very much.